Good morning, everybody. Thank you for joining me today. I appreciate it. I will be speaking for the Momentum Institute and Expo virtual presentation on the 23rd of February. I'm going to be talking about financial management of services funded by public programs in assisted living, section V as in Victor 1503. And we'll be presenting for an hour from 10 a.m. to 11 a.m. Now keep in mind that elderly waiver and financial, an hour is just not enough to cover all of that. So if you have any questions, you feel free to reach out to me personally, and I'm sure that Ashley will give you that information if you ask for it. My name is Lisa McNeil. I'm an RN and BSN from Bemidji State University. I also hold an LALD licensure, and I work as a consultant and in development for Uvoya Senior Services Consulting in Woodbury. I've been consulting for about 7 years. I have worked with several different partnerships and in a variety of different roles between interim, survey recovery, budgeting, packaging, CADI, EW, kind of done it all. So feel free to reach out if you have any questions about other items as well that might not be mentioned in the elderly waiver and CADI presentation today. So our learning objectives are to discuss the differences between elderly waiver and CADI as sources of public funding used by older adults living in our assisted living settings. We want to understand what waiver programs were designed to accomplish, specifically what they will pay for, and the maximum reimbursement rates allowable under each. We're going to learn how to complete the customized living tool so we can accurately capture reimbursement for services provided. Now with the CL tool, there's also the name 6790 or RMS. They're the same. We'll get into that. So if you're confused as to the customized living tool verbiage, there are a couple other ways to state what that is. So let's go into the history of waiver programs. Waivers began in the 1980s. Minnesota is generous compared to other states if you look at our reimbursement rates for waivers. Growing numbers of persons served, baby boomers, and large increase in housing with service establishments. So back 20 years ago, when a lot of us were working in nursing homes, we did not have the AL facilities like they do now. And a lot of the assisted living folks that are coming up in the baby boomer age now are actually going to assisted living facilities or independent standalones, and they're like the old nursing home people that we used to have 20-30 years ago. They're higher acuity now in assisted livings, and so we're seeing a lot of those folks in these assisted livings now. The state budget influences reimbursement for these programs, and they're run by county within the state, and we'll get to that when we get into the CL tools because they are a little different. And then the federal HCBS settings rule. So the HCBS rule, which is Home and Community-Based Services, is the final rule that addresses several sections of Medicaid law under which states may use federal Medicaid funds to pay for home and community-based services. The rule supports enhanced quality in HCBS programs, adds protections for individuals receiving services, and in addition, the rule reflects CMS's intent to ensure that individuals receiving services and supports through Medicaid's HCBS programs have full access to the benefits of community living and are able to receive services in the most integrated setting. So that brings us to housing support. We're going to go through the general idea of elderly waiver and CADI waiver. It gives you a little bit of a foundation there, but like I said before, it's not going to cover everything that has to do with the EW and CADI system. So housing support. Housing support is formerly group residential housing. It's a current rate of $9.54 a month. So when you think of the $9.54 a month, what that means is if you have an assisted living facility, let's just say that rent is $2,800 a month before your services are added on top of that, like bathing, dressing, medication management. So that $9.54, no matter how much your rate is, if you're in an assisted living facility that charges $2,800 a month, you're only going to get $954 of that rent from the state when they're on an EW or CADI waiver. The county will actually figure out the payment system as far as what they may have for money coming in, like any kind of retirement, Social Security, anything like that. They'll take care of that, and it all kind of fluctuates based on what the resident is bringing in at the time. So $954 covers the food, congregate, 3 meals a day on site plus 2 snacks, a bed, clothing storage, linen, bedding, laundry supplies, utilities, maintenance, insurance, property tax, and debt service, but it may not cover everything in your rent package. So if a facility has a packaged rent, they may offer other things like transportation that's not medically related, etc. And that would be something that the resident would have to come up with on top of that $954 a month on their own. Not covered in housing support, operating costs above and beyond the rate limit, and any service that could be covered by elderly waiver. So what you want to think about elderly or CADI waiver is there's a care piece and there's a rent piece. So that $954 is the rent piece, and now we're going to get into that care piece. So for waivered programs, who qualifies exactly? So elderly waiver, that's for your folks aged 65 and over, for people who need the level of care provided in a nursing home, but who choose to live in the community. Again, like stated before, the nursing home people from 20, 30 years ago that we were taking care of are basically what you're having in the assisted livings now. The nursing homes are a little more higher acuity now. They didn't have the TCUs like they do now, or the specialty care. You must qualify for medical assistance to be eligible for that program. So CADI waiver, or Community Access for Disability Inclusion, is under the age of 65 at the time of opening the waiver. So that's something you also want to look at. In several facilities that I go to, they're right on that cusp of becoming 65 years old and they're on CADI. So you want to make sure that you keep in touch with that worker about that needing to change. They also are eligible for medical assistance. They're certified disabled by the Social Security or State Medical Review Team, SMRT process. They're determined by the case manager, service coordinator to need nursing facility level of care. And they have an assessed need for supports and services over and above those available through MA. The higher level of need, nursing home level of care, is defined as the need for one or more of the following: need for restorative and rehabilitative or other special treatment, unstable health, need for complex care management, they have a functional limitation, existence of complicating conditions, cognitive or behavioral condition, fragility or vulnerability. So with elderly waiver, what is included with elderly waiver? Well, we have non-medical transportation that's included, personal emergency response systems, personal care assistance. Now, I do want to go back. The personal emergency response systems are your pendant systems, call-out systems. Keep in mind that if you are in a assisted living that has a memory care, they still need a pendant system, a calling system. The regulation does not differentiate between whether or not they are cognitively impaired to use that alerting system. So you have to have something in place for that, regardless of memory care versus the AL side. Residential services such as a customized living service, foster care, or other type of residential care, skilled nursing visits, specialized equipment and supplies, wipes for incontinence care. Now, wipes for incontinence care we'll get into a little bit further down the line as well, but your active style, your handy medical, anything like that, a lot of times will not cover incontinence care wipes unless they are fully incontinent of bowel. You can get some luck with the wipes being covered if that is the case, but a lot of case managers and workers with elderly waiver and caddy will actually wrap that into the incontinence care for you. They're very good about that if you ask them for that. So what is not included? Medical transportation that is covered under Medicaid. An example would be Metro Mobility, room and board, which again, you know, that $953 covers that. Incontinence products, briefs, pull-ups, pads. Keep in mind, again, like services like Active Style or Handy Medical will set up an auto delivery for residents needing incontinence supplies, and they will bill their medical assistance or insurance. So if you set that up with them, they will also do supplements if there's an order. They do quite a few things. Chucks, I've had them deliver before, which is really nice. And even some intermittent catheter supplies they will send as well. And they'll call you before they send out those items for you and ask if you're in need. They will also ask how many briefs or how many supplies they use daily so that they can get an accurate amount to send out to you. And socialization that is recreational in nature. Customized living covered components continued. Activities of daily living assistance. ADL assistance includes assisting the person with bathing, dressing, grooming, transferring, walking, continence care, eating, positioning, using a wheelchair. So I want you guys to think about, with the new licensure, your monitoring visits and your comprehensive visits too. You know, your monitoring visits would be for people who are just getting your basic bathing, grooming, transferring, without that special task like medication administration, maybe TED socks, wraps, anything like that. More customized living covered components would be health related assistance, which would include assistance with therapeutic exercises. A lot of times if they're using therapy will put an exercise program in their room, stretching exercises or leg lifts or something for them to be doing on their own or for staff to be helping them with. Delegated clinical monitoring and delegated nursing tasks. Okay, so delegated clinical monitoring and delegated nursing tasks are two different things on that CL tool, the 6790 RMS. So you want to make sure that you talk to the case manager if you're having any difficulty trying to figure out where to put the time for those items. So your delegated clinical monitoring might be monitoring for bleeding because they're on an anticoagulant, monitoring a blood pressure or a weight for a medication, anything like that. Delegated nursing tasks, different. Delegated nursing tasks would be maybe you're delegating a specific type of wound care. Now, if you're going to be doing that delegated nursing task, you have to make sure that you're actually offering that education and competency for that specialized nursing task as well, and keeping that on file that you have completed that with your staff. Very important because they'll ask for it. State will ask for it if they come in. Help with medications, setting up and monitoring visual or verbal reminders, administration or assistance with self-administration. Please keep in mind, Again, that 144G new regulatory compliance about the monitoring versus comprehensive assessment. If the resident is taking medications on their own after setup, that's not considered something that would be a comprehensive task. That is a monitoring task. If you are actually administering the medication to them, that would be a comprehensive task. It's a special task for those residents. If you have questions about that, you can certainly reach out and ask, or just take a look at that new regulation. Insulin draws and injections, summoning devices, which we've already talked about. And remember that medication setups include time spent for checking in medications and coordination. This is a big one. I get asked this a lot with elderly waiver and caddy waiver. There is a specific area for that med setup time, and people think that that's that weekly setup med minder, and that's setting up that medication for them, when it's actually the setup is counting in the medications, reordering the medication, coordination with the pharmacy. That is your time spent just setting up the medication, not actually putting pills into a MediMinder for them to take later, or for you to administer. Home management tasks. So home management tasks can include assisting the persons with arranging transportation, housekeeping, heavy and light. Remember that those are billed separately. So if you're going into a resident's room every day and you're taking out garbage, spot cleaning, maybe you're doing a few dishes, you're pulling the drapes, pulling up blinds, making that bed, anything like that, that would be considered a light housekeeping task. And you may spend any time from 5 to 10 to 15 minutes in that room every single day. Then your heavy housekeeping would be, usually it's once a week. Some people call it a deep clean, some people do not. They just call it a heavy clean. And that would be your vacuuming, scrubbing the toilet, washing the floors, anything like that. And that's billed in a different way on that CL tool, which we will look at. But you want to make sure that you're claiming both. You're doing that daily task and you're doing that weekly task on top of it. Laundry, personal items and linens, and we'll get into that laundry as well. Laundry, if you're doing the personal linens, that's a separate billing. You're going to bill for washing those linens, stripping the bed, washing the linens, putting them back on the bed, all of that. And then you have their personal laundry, their clothing items as well. Meal preparation. So if you're doing meal preparation and you're going to be claiming that on a CL tool, you have to be in the person's own living unit, and congregate setting is billed separately. So if they're going downstairs and they're getting 3 meals a day, because that's what your facility is providing, and their 2 snacks, that is not meal preparation in the person's living unit. That is if you're actually going in there and you're preparing something for them to eat. Like maybe you're making toast for them every morning and preparing something else for them, eggs, whatever, bacon in the microwave, I don't know. But that would be considered you're making that meal for them. Money management. So we do offer that money management. It usually happens when a resident wants to lock something up in the billing department and wants to help us manage with their bills, because they may not have somebody that can help them with that. It does not happen very frequently. Scheduling medical and non-medical appointments. So you want to make sure that you are also claiming the time that you are spending scheduling those medical appointments and non-medical appointments. So if you have somebody going out, let's just say for orthotics or something like that, you want to be billing because you are setting up that appointment. It takes a long time to set up an appointment, arrange transportation if the family's not going to be taking them. Same thing with the medical appointments. Maybe they're going out to the dentist, or they have a hearing aid that's being fitted, vision, anything like that. More often than not, family will take them out and they will help with that. And sometimes they'll even schedule those medical appointments. But quite frequently the nurse is doing that in the facility. Not to mention that in a lot of facilities, we actually have nurse practitioners that come on site, and you are actually coordinating with the scheduling for those in-house providers. So you want to make sure that you're taking that time of scheduling, and some people take a lot more time than other people. If you're in a facility that has significant mental health issues in it, you're doing psychiatry appointments, and you could be doing ACP psychology appointments on top of all of that in-house nurse practitioner visiting as well. So you need to keep in mind you've got to claim that for yourself. And shopping. So I've been in several facilities too where they may have a HOC or a unit coordinator which can go out and buy toiletries and different lotions, shampoo, whatever those personal needs are. EW and Caddy gives a stipend every month. It's a small stipend. It's around $100 a month for personal necessities for residents. So frequently they will have people go out when these residents are unable to, and they will purchase their items. So do not forget to claim that on there as well. And then we also want to keep in mind too that if you are doing the meal preparation in the congregate setting where they do have the 3 meals a day and the 2 snacks, that it has to be adequately meeting the needs of that resident as defined by the FDA. So do keep that in mind, that they have to be balanced meals. And some facilities will do special diets, others will not. I do encourage facilities to try and move to a little bit more of a special diet if they can, because I have seen a lot of residents get turned away for admission because they will not do a soft diet or maybe a gluten-free. I see that a lot, the gluten-free, the lactose-free. If you can make some special accommodation for those residents, you're going to be able to admit more if you're having problems with census. Non-medical transportation. So non-medical transportation includes transportation of the person to support their access to the community. So you may have the activity director and activities department do weekly outings to Walmart or the dollar store. I see that a lot. I mean, it's a big deal to these residents just to go to the dollar store and pick up their treasures. So they may be doing that weekly, maybe it's monthly, maybe they go out and have a drive and look at leaves or Christmas lights. That's all something that you want to include in that non-medical transportation as well. Socialization, that's huge, huge. A lot of facilities, all facilities really needed to beef up their activities department in the assisted living environment now. So there's a lot more of that socialization coming out, especially now that COVID, 2 years ago with COVID, we didn't see any activities at all. And these poor residents were locked up and very lonesome, as we all know. It was very devastating to see. It was an unfortunate situation just because we just didn't know enough about it. Now you're seeing that open up a lot more. Residents are wanting to come out more and participate, and we want to see them out in the community and being part of a bigger group so that they're not feeling so isolated. Mental health and behaviors. So this is a big one. I would say 95% of the facilities that I see, and I see a lot of them, have a lot of mental health and behaviors. It's only getting more and more prevalent in facilities, more mental health coming to the surface for residents, and we want to make sure that we're claiming what we're doing for those residents, especially when you're looking at a memory care facility with that behavioral intervention. And you also have to remember that when you have assisted living memory care, odds are that these are folks that are still able-bodied, able to get up, able to move around, and they can be a challenge when they're hard to redirect. So you want to make sure that you're trying to get all of that revenue when you're filling out those tools, and we'll talk about that as well. So behavior management and mental health support can be time consuming and costly. I would say very time consuming and costly. It is critical that you ensure that behaviors are documented and included on the customized living tool for maximum reimbursement. You got to document this stuff. So if you're using an EMAR system, make sure that there's something in place so that the staff can readily document behavior intervention. If it has to be on paper, put it in a binder. Maybe have slips that are down in the office so that staff can write down that extra time that they spent trying to redirect somebody. You know, most times it's going to take some doing to get somebody redirected in a memory care unit. Especially when they're able-bodied like that. So assistance with mental health, cognitive, or behavioral concerns includes assisting the person with agitation, anxiety, orientation issues, physical aggression, property destruction, self-injurious behavior, verbal aggression, wandering, and other mental health, cognitive, or behavioral needs. Now, I do want to mention as well, you know, we talk a lot about the elderly waiver folks. Oh, elderly waiver 60, 65 and over. You know, they are the ones with the dementia. They are the ones with the cognitive deficit. Not true, because you have a lot of people who are on CADI waiver that are under the age of 65 with alcoholism, anxiety. They may have brain damage and cognitive delay from drug use and abuse. And when the younger folks that you get, the more able-bodied they are, they can be quite a big problem in a lot of time. So you want to make sure that you're able to meet their needs too. And what I do love to see when I go out is that a lot more places are accepting elderly waiver and CADI, because these folks do need to go somewhere. We can't keep turning them away because of their mental health status. It's just the way the world works now. There's a lot of mental health out there. I want to mention in that tone too that there are several facilities that all they take is elderly waiver and CADI. And then there's some privately owned facilities too that don't take any elderly waiver and CADI. What I see, most facilities take between about 15 to 25% CADI and elderly waiver. They'll have a certain amount of beds that they're willing to put aside for elderly waiver, and then the rest will be private pay. There are other instances where I see facilities who do not offer elderly waiver and CADI. The resident would come in and have maybe 2 years of the ability financially to pay for their care and their rent just for that 2 years, and then they would have to start looking for a place that would accept the elderly waiver or CADI services. So it can be pretty complicated, especially for family members when they are looking for a place to service their loved one. Mental health behaviors, care planning, and documentation. If the person receives any of these component services, the following requirements must be met. The support must address a need that has been assessed by an appropriate professional. So a staff member just can't say, oh, this person just has anxiety and I've diagnosed them and they've got anxiety, so no, I'm going to claim that I had to redirect their anxiety, you know, an hour a day. They really have to have that diagnosis by a professional psychologist, psychiatrist, or maybe they have a dementia diagnosis, or perhaps they already have the anxiety depression diagnosis, but they have to have a diagnosis before you can actually claim that time that you're spending for them. So if you see a change in the mood or cognitive ability of someone, you really do need to address that right away, so that you can get that diagnosis, get the proper placement, get the right tools in place, and get that reimbursement for them. There must be a plan to implement and monitor the support. So how are you going to take care of these people? Now, some of these RMS tools are going to ask you, how do you train your staff? And we'll get to that because I have some examples. And how do you monitor your staff? Well, you know that with assisted livings, they have to do the initial dementia care training, even if they're not in a dementia care unit, and then they have more dementia care on top of that. They are trained in behavioral responses, professional boundaries, all of those items are trained. And then they are also given the competency training on top of that. So you want to make sure that you are compliant in your training. It is something that will be looked at and scrutinized. So make sure that you have a good training program in place and compliant training in place. There must be a plan to provide feedback on the efficacy of the support. So how well is it going? Are your interventions appropriate? Are they working? Are your medications appropriate, and are they working, or do we need a change? You have to keep that dialogue open between your facility and the provider, no matter if that's a psychiatrist, psychologist, nurse practitioner, even your staff. That dialogue has to be open. You need to know what's going on with your residents. And staff must receive training specific to the person's needs. So depending on what that resident's needs are, a lot of it's with CADDY. Okay, so if you have a CADDY resident, for instance, that has severe drug and alcohol abuse, how are you going to meet that person's needs to help them to not, have that problem with alcoholism, depression, drug abuse? What are you going to do to address that? And that's just an example, of course. There's a lot of different mental health needs. So what I'm going to show you now, this is an actual CL tool. So this is that whole customized living provider input form. So it's going to look just a little bit different than the other two I'm also going to show you, and that's the 6790 and the RMS tool. So what they would have here is you would be checking off if they have a single room, or if they're in either own apartment, single room, anything like that. Then you would put in if they're sharing the space, all of their pertinent information in here. And then in here, with hearing, vision, and communication, do they wear hearing aids? Are they hard of hearing? Should you be speaking in one ear and not the other? Do you need to face that resident? All of those different items in there. Vision, are they blind in one eye? Do they wear glasses? Or do they just use cheaters? Maybe they just use reading glasses. Or maybe they have cataracts and they can't see very well at all, even with their glasses. And you want to make sure, of course, that you're addressing their vision needs. If you see it start getting a little bit rough, you want to take care of that for them. Communication. How do they communicate? Do they have to watch your lips when you're talking? Do they use English? Do they speak a different language? If they speak a different language, what are you using for an interpreter? Do you have a call-in service? Do you have an interpreter that comes into your building? I've also seen the ones that are virtual, where an interpreter will just pop up on the screen and then interpret for you. Those are really nice programs. Now we're going to get into that light and heavy housekeeping, like I said. So when you put in your light housekeeping, you have to put a description in there. You're going to say garbage removal, opening blinds, spot cleaning, dusting, just spot dusting though, not your deep cleaning. Maybe making the bed every morning. So you're going to put, or if it's decluttering. A lot of residents, they are hoarders. There's some mental issues there as well. Maybe you have to pick up papers all over the floor every day, and so it's safe so they don't walk through papers and fall. So you want to claim that time. So in the minutes per day, you're going to put those minutes per day in there. It might be 5 minutes, could be 10, 15. So what Elderly Waiver and CADDY will pay is usually it's in sections of 15 minutes. at a time. So if you're doing 5 minutes a day, then you're looking at 35 minutes a week. And then you have your heavy housekeeping. And your heavy housekeeping, like I said, is usually your mopping, your scrubbing of toilets, your vacuuming. It's about 30 minutes, depending on the resident. I mean, I've seen people that are really quite messy and maybe taking 45 minutes to an hour a day, or I mean, excuse me, not a day. It shouldn't be a day, a week to get that apartment cleaned up. Laundry, personal laundry. So you need to also keep in mind with personal laundry, are they incontinent? Are they dirty? You know, how much laundry are you really doing during that week? You know, are you picking it up a couple times a week? Are you only doing it once a week? Are you doing it every couple weeks? You want to make sure that that time is accurate. So if they're incontinent, odds are you're probably doing a couple, 3 loads a week on that resident. If they're just your average person and it's 1 load a week or a couple loads a week, you want to make sure that you are also putting in that linen piece underneath that too. So how long does laundry take? Well, you know, you may have a couple loads of laundry that you have to do a week. You need to take into account how long does it take you to get that laundry together? How long does it take you to pick it up? When you bring it and you wash it, how long does it take you to sort the laundry? How long does it take you to put it in there, put the soap in, do the laundry, transfer the laundry from the tub to the dryer, dry it, take it out, fold it, and put it away. So when you start thinking about all of those different aspects of doing laundry, it takes a little bit of time. So you may have 45 minutes for a load of laundry. You may have an hour, because I mean, if you've got some incontinent folks, you've got to rinse that stuff out and then you've got to put it in the wash machine, right? That's how that works. So you want to make sure you're claiming all of that time. Same thing with linens. So when you talk about linens, okay, you're going in, you're removing the linen off the bed, you're putting it in the basket. You're putting new linens on the bed, and then you're taking these linens, you're sorting them, you're putting them in the wash, you're doing the load, putting them in the dryer, and then you're folding them, and then you're putting them away again. So I want you to remember that takes some time to get that done. So that's all there. The shopping is there as well. Breakfast, lunch, and supper and snacks. It's always going to be 3 meals a day and 2 snacks. So that's an easy one. Making appointments. If you're making appointments for a resident who is complex and they're seen weekly by the nurse practitioner and you're coordinating all of that, odds are you're probably spending 30 minutes a week coordinating for a heavy person. Otherwise, if they're stable, it may be 30 minutes a month that you're doing that for. But you have to make sure that that coordination is correct. Same thing with, you know, maybe they're seeing ACP and a nurse practitioner inside, and maybe you're doing a virtual meeting also with their psychiatrist. Make sure you are claiming all of that time. And it can be time consuming filling these tools out because of that, because you have to get through all of that information and figure out what is the time for that and getting it into that reimbursement tool. It is important that you get it in there correctly because you need to have the staff to be able to perform those tasks. Okay, so let me just give you an example. Most of the case managers I work with from the county are lovely. Find a couple that you really like, and if you have questions, they're always available. I have a couple that I use that are just fantastic. I have one from Ramsey County and one from Hennepin County that I contact the most, and you know who you are. They're fabulous ladies, and they are always there for me. So if I have a question about something, they have an answer for me. They know their stuff. They've both been in the system for over 20 years, and they're wonderful. So don't be afraid to reach out to a caseworker and befriend them and bounce some ideas off of them. They will in turn come to you for some questions too, I'm sure, as far as nursing is concerned, and you can develop that relationship with them. Now, that being said, there are those case managers that you have to keep in mind that their job is to make sure that the monies being spent by the county are appropriate. So they are going to question you. They are going to say, I don't believe that this is 20 minutes. I think it's 15 minutes. And they will banter back and forth with you and try and come up with a happy medium. So with that said, when a resident first moves into the facility, that caseworker wants that CL tool 6790 RMS right away so that they can start plugging that reimbursement tool in. It is very difficult to do that tool when you don't know that resident. So you do the best that you can with the information that you know, and you form that relationship with that caseworker so that you maybe in 30 days, 60 days can go back and add things or take things away if you need to. Usually it's not taking things away. That happens very rarely. Once in a while it does. It's usually, you know, the person is actually more intense, more needs than you thought you needed, and revisiting that in the 30 to 60 days so that you're getting the reimbursement. You can always email your case manager and let them know if there's been a change, and they're very good about getting that time on a new tool for you so that you can get that reimbursement. They will also backdate it if at all possible and do what's called a take back. So you may have a resident that maybe the CL tool was not filled out appropriately and you're finding that they needed a lot more help than what was put on that tool. You can talk to that caseworker, see if they'd be willing to change that tool, and a lot of times they'll take a take back, they'll get the money back that they paid, and then they'll go back a few months and send you a new amount for what we missed, which is fabulous. It's wonderful. It's a lot of work for them, so we always appreciate when they will do something like that. So let's get back to the CL tool. So socialization. So are these residents getting one-on-one socialization? We saw this a lot with COVID. When we had residents that were in their rooms and they weren't able to come out like they used to, and they needed a one-on-one visit. So a lot of recreation therapists, life enrichment would go in there and they would do one-on-one visits. So you want to claim that. Or they would do very small group activities from 1 to 5 residents in small, open areas. We still see that a lot. For group socialization of 6 to 12, we see that a lot in memory care. Are you doing an activity with memory care? Like, for instance, this facility that I'm at right now, we did gingerbread houses and cookies and stuff like that. So that was that socialization for them. Or maybe it's a small group of bingo. Maybe it's a movie night. Whatever it is, you want to make sure that you're claiming that. And then your group socialization, your big ones, your 13 to 20 residents, that's almost always bingo. They love their bingo, or they may be having a categories game or something like that. So you want to make sure that that resident is getting out there and having a good time. Transportation, non-medical transportation, maybe you're arranging transportation for shopping for them or something, you want to put that on there. Group non-medical transportation, and then it's got the riders down there. As I said before, this could be your dollar store outings, your Walmart outings. We're going to look at the leaves. We're going to go look at the Christmas lights. Make sure that you've got that on there. Personal care, dressing and grooming. How long is it taking you to dress and groom these folks? Are you just setting them up? If you're setting them up, it's probably going to be 5 minutes of your time. If you're actually helping them get items on, it's going to take longer. It's going to be 15 minutes for grooming and dressing. So it's going to be 30 minutes for you in that area. Bathing, you know, are we setting them up? If we're setting them up and we're washing their backs and providing safety, it's 30 minutes. If they are a full-on bath and you are doing everything for them, it's probably going to be 45 to an hour. And how many times are you giving a bath a week? You know, residents have the right to be bathed however many times they need to be bathed. So are you doing it once a week? Are you doing it twice a week? Some people like it 3 times a week. So you want to make sure that you're putting that time in there. Eating, okay. So with eating, are you opening containers for them? Are you getting them their drinks? Are you arranging their food? Are you cutting their food? Are you cueing them to eat because they've got weight loss? You want to make sure that you're claiming that. For instance, if it's breakfast, lunch, and dinner, and you are getting them their drinks and you're cutting up their food and you're arranging it and everything for them, that's 5 minutes for each meal. So that's 15 minutes a day that you may not be claiming for assisting them with eating. Now, keep in mind that with COVID, I know that we were delivering to the rooms a lot for COVID, and I'm using the styrofoam and the boxes, the cardboard and everything, bringing that to them. Caddy and Elderly Waiver do not, I repeat, they do not reimburse for delivering meals to rooms. Okay, so you keep that in mind. But if you are delivering these meals to their rooms and you are providing them their drinks, you're cutting their food, you're arranging it, you're doing any of those tasks, you are spending 5 to 10 minutes in that room depending on what exactly they need for that. If you're cueing them, it's going to be over 5 minutes because you're cueing them to help them eat, to keep them on track. Walking and wheeling. Are you walking that resident to and from meals? Are you wheeling them to and from meals? Are they going to different activities and are you wheeling them there? I know a lot of times residents may be too weak to get up to the front of the facility for a visit. Are you taking them there? Make sure that you're putting that down there as well. Positioning, are we helping position them in bed, in their chairs? We all know how residents love to sit in their recliners, right? And they have to be repositioned. They can't just lay there all day long. They're going to break down. We have to get them up and we have to get them moving around and repositioning. Okay, med administration and assistance. So with med administration, are we giving them verbal cues? Are we setting them up in a med minder every week and then providing them the verbal medication cues? Are we administering the medication? Are they complex medications? Are there 10 or more medications? Are we doing insulins? Are we doing inhalers? Are we doing eye drops? That's what's going to hinder that time. So you may be in there and you're doing some simple medications for them. Maybe it only takes 10 minutes. And you're doing 3 medication passes a day. So that's 30 minutes, right? But now let's add in, we're doing 15 medications, which is what we see in geriatrics. And we're doing complex inhalers. And then we got to do eye drops and we have to wait 5 minutes in between. Or we're setting up a nebulizer treatment and leaving and coming back. That is very time consuming. You might spend 20 to 30 minutes in one med pass for a resident, and that's 3 times a day. So make sure that you are explaining it and that you are claiming it. So like if you're writing in here all of those tasks that you're doing for medication, you need to do that. So if a care manager questions it, it's there. And they don't have to call you and say, well, what exactly are you doing? Send them a face sheet, send them a medication list, care plan, and the CL tool, and they will see it for themselves. Delegated clinical monitoring, as I said before, and this one states in that CL tool some of the things that you might be doing for them. Glucose checks is one of them. And we see that sometimes 3-4 times a day. Monitoring for bleeding, like I said before, maybe you're monitoring for shortness of breath, monitoring edema, blood pressures, vital signs, anything that has to do with a clinical need, that's what you want to put in there. And then you have your med setups and monitoring. And as I had said before, this would be your coordination of counting in medications, getting medications out, coordinating with that pharmacy on what's going on. And that is usually 30 minutes a week. It figures out to be, especially with your cyclophil and everything, usually that's what it is. Because cyclophils really do help out a lot. If there's insulins or eye drops that need to be refrigerated, anything like that, it's going to take a little bit longer, so make sure that you claim that. And then your behavior issues. Are they wandering? Are you having to orientate them frequently? How hard are they to reorient? How hard is it? They might be not easy to redirect. And so you want to make sure that you're putting that in there. Anxiety. A lot of what I see is the repetitive behavior, the same things over and over again, and having to redirect them continuously throughout the day. Property destruction, that does happen. I usually see it. The property destruction I will see frequently more with people who are in scooters, actually in the AL part. Well, they'll run into walls and stuff like that and destroy property. But you do see it in the memory care as well. They might get angry and throw things, maybe dent things, throw things around, and you have to put that in there as well. And other mental health, cognitive challenges, frequency of contact. You know, if there's just nothing here that you can put it under, make sure that you put it in there and explain yourself in there, and the case manager will have an easier time approving that tool. Okay, so we'll go through cap limits here. Here's an example of Dakota's cap limit. So depending on what their case mix is where their cap is. So elderly waiver and CADI programs have a county payment cap limit on services based on level of care, need, and assessment of the county worker. A care choices assessment would be an example of this. So a county worker comes out and sees your resident, and they assess that resident. And it's usually every year from what I have seen. And it could be with change of condition as well. I'll get back to that. So they come out, they determine that this person is a B case mix, and they're in that level 3 depending on the county cap limit. Okay, so you're either in group 1, 2, 3 depending on what county you live in and the reimbursement rate. So this specific one is $62.98. Now with this specific resident, this was one of my residents, and the county case manager came out and said, well, this is what she's at for case mix. We were very far apart. From what we saw, it was much different. And, you know, we went back and forth on the reimbursement rate, and eventually we did come to a conclusion that she would need a change of condition done because we were too far apart. And that's okay, you can ask for that, and they will come back out and do another assessment, and then they will be able to adjust that customized living tool, $67.90, to match that case mix so that you get that reimbursement. I know that's really confusing. Hopefully I explained it okay, but if you have any questions, please let me know, because it is quite complicated if you don't understand the EW and CADI rates and caps. So the $67.90, as we had talked about before, will automatically load down a drop-down menu for selection, and a detailed summary must be provided, including delegated tasks, specific behavior, and how staff is educated to deal with those behaviors. I talked about that earlier. The $67.90 will need to be downloaded into Adobe per instructions on the initial page, and some counties will not accept the $67.90 and may ask for an RMS form or CL tool per their specific county. This can be a little frustrating because they're different. Different counties will want different things, and you may fill out that $67.90 drop-down that's on the Minnesota Department of Health site, but they want an RMS tool or a CL tool. So you can copy and paste that information in. It's going to be a little more time consuming, but if you talk with the caseworker and see what exactly they would like for that county, it's going to save you time in the end with that CL tool. Okay, so I'm going to show you the CL tool below. In this case, the resident has a higher level of care needed than was evaluated per the care choice assessment. The care choice assessment is a level B, as I showed you in the cap. The nursing assessment is a higher level need. When this happens, it can be very time consuming, and if the caseworker and the nurse are unable to make an agreement on payment, another care choice assessment should be done. The nurse can request a change of condition, as I stated before. Remember, the staff providing direct care to the resident knows the resident best. The county assessor only sees the resident for a short period of time to assess them. Do not be afraid to ask what you need to provide for the needs of the resident. And keep this in mind, everybody, this is important. If you are unable to come to an agreement, it may mean the facility is unable to meet the needs due to lack of reimbursement. Per regulation guidance, the facility must staff per acuity and needs of the resident. So if you guys cannot come to an agreement on the time it's going to take you to get the staff in to take care of that resident per the acuity of needs and regulatory compliance, you cannot take that resident. So make sure that you're able to come to a fair agreement with the county assessor so that we are able to take that resident and get them the care they need. And here is that drop-down menu. So you go to the Department of Human Services, and they will have this continuing care worksheet 6790, okay? And you're just gonna type all of this information in there. The NPI the provider will have and give that to you. The PMI is their Medicaid number. So you can put that in, I get that a lot. What is that PMI? It's their Medicaid number. And you're going to drop down, so service home management, and then the housekeeping, and you're going to put those hours in. Making appointments, as you can see, hers is, she's pretty stable, so it's a half an hour a month. Socialization, very social person, so she's got several hours of that, breakfast, lunch, supper, snack. The mileage, because she does go out. Assistance in dressing she's pretty easy. We're just standing by her for safety and doing some of the tasks as far as handing her items and everything. Assistance with grooming, same. Bathing is a half an hour a week. Continence care, we're helping her with her continence care. Eating, again, we're just setting up for her. Delegated tasks, self-administration, she's very repetitive. And as you can see in the summary below, all of these are the items that we do for her. You need to put in a specific summary. What are you doing for her? How do we intervene with her repetitive behavior? What kind of medications is she getting? Is she being seen in-house? I also put her slums down so they can see that she's in a memory care and she has a low slums. This is the Hennepin County waiver rate management system. So this is what they ask for in Hennepin County. So it's the same kind of thing. You're going to fill out all of this information. The differences are that they want more specific information as far as, let me get to it here so that you can see. As you can see, like the ADL assistance is more descriptive and what they need and what you need to write in there. There is also, see, here's some more delegated tasks here that I didn't mention. It's very helpful to see. Effectiveness of med setups and monitoring. So managing all of these behavioral issues, what are the considerations for that? This is very interesting how they do this. Their sleep schedule, day program, anything like that. They like to have that extra information. And the plan to implement and monitor the support, the staff training, that's a big deal. What did you do to train those folks? And professional who assess the need approved the intervention and their title. So the nurse is usually that person that would be approving that and writing down their name and title. So as you can see here, they have different behaviors that are targeted. They have a few different sections that are the same. So you're going to show them the specific behavior and everything that you're doing for that behavior. Extra assistance for waivered residents. We'll go through this here real quick because I'm running out of time. Like I said, you don't have a lot. An hour just is not enough to cover CADI and EW. It's intense. There are resources available for assistance with resident care needs and moving reimbursement. Elderly waiver does not cover these expenses. So for instance, I've had good luck with these folks when we're moving a resident from one apartment to another apartment who might be have a lot of stuff from home, and we just don't have the staff to help move them from one place to another. And I've had very good luck getting help from these couple places, so I thought these would be a nice reference for you guys to have in case you needed it. Like the Metropolitan Center for Independent Living, I've used them and had pretty good luck with them. They're very nice. So that's one of the nice tools in here that I'm giving you that you may need. Residents can get information and assistance with applying for benefits by contacting the following, and I have all of that information down there for you. So please feel free to use that. And all of these links for you, and how to get the cap limit example, the 6790, the CADI, residential services worksheet, the RMS worksheet. And now if you have any questions, from what I understand, I will be on here answering questions while you're watching this virtual presentation. And I thank you for your time. We ran a little bit over, so thank you very much. It's a lot to cram in when there's a lot to talk about with elderly waiver and CADI. But I am here, and I am always willing to answer any questions you might have. Full disclaimer, I am by no means an expert in elderly waiver and CADI changes. I'm not a case manager. I reach out to the folks that know their stuff, and they make me look good because they answer my questions for me. Don't be afraid to ask questions. Reach out. If I don't know the answer to something, I'm not going to pretend like I know the answer, because I don't. I know who to call to get that answer. So please feel free to ask questions. If I don't know the answer, I will be happy to reach out to somebody that does, and I'll get back to you. Okay? Thank you so much for your time. I appreciate it. I'm going to flip through these last couple slides for you, and so that you have an opportunity to write down these links if you need to. And